Well, thank you all for being here. I am Simon Holland. I'm deeply honored to be able to give this talk. I've been involved in Orbis since the beginning in 1982, and I'm a former graduate of the University of Zimbabwe, but I now live in Canada. I'm doing corneal surgery at the University of British Columbia. So I'm excited to tell you something about an intriguing subject. It's this TASS. I'd like to acknowledge my co-authors and all those who helped putting this talk together. There are no financial disclosures. Next. This is an example of what TASS can look like on the first day. Very faint inflammatory membranes and a fairly quiet eye. So what is TASS? TASS is sterile inflammation. It's not infectious. It's often confused with infection, but it's very different. Usually occurs after anterior segment surgery, particularly cataract surgery. There's also a variant which is a real corneal endothelial toxicity, which differs in several ways. The condition is multifactorial, and it is often very difficult to detect the cause. It's estimated that about half the cases are related to the medical device reprocessing or the SPD, and the culprits are usually toxins, enzymatic cleaners, dried viscoelastic, and residue on gloves. The most important aspect of this condition is that one has to rule out endophthalmitis, with which it can be easily confused. Next. Looking at the instance of TASS, one of the best indicators we have is from India with Aravind that did studies showing that overall one can expect an incidence of about 0.2%. It doesn't sound like a lot, but when given the volume of surgeries we do now, that's a considerable amount. Due to the issues that occurred with TASS, there was an incentive to produce some sort of help for those practitioners across the world who've been affected by this condition. This was as the ASCRS TASS task force formed in the 2000s. Recently, there's been success with a decrease from 472 per annum down to, in the period up until 2011, but down to 49%. So a 10 times reduction in TASS due to multiple efforts across the world. The Canadian story is we have formed our TASS task force to try and deal with the problem. So far, we have dealt with 38 outbreaks and 12 hospital closures. TASS occurs predominantly as two forms. One is sporadic, which is, for want of a better way to express it, is isolated cases separated by more than 2 weeks, normally called a cluster or an outbreak if it's 2 or more in less than 2 weeks. Next. So again, as I mentioned earlier, there's been a 10-fold decrease in TASS since the origination of the task force. And this has proven to be very useful, as you can see how the numbers have decreased over the years, but are still a considerable problem. Next. We have seen in the last 15 years an increase in the use of intracameral, as injecting inside the eye after the end of surgery, up 100 times. The cleaning of the ultrasonic bath has also increased. Practices that are almost dying out are those related to the use of tap water to flush the handpieces when it's not sterile. Adding antibiotics to the BSS has not been found to be useful, and using the higher concentrations of lidocaine intracamerally can be a problem in the causation of TASS. So next. So what are the features? TASS is generally asymptomatic. The patient may have some blurred vision, but pain is rare. And that's an important sort of early clue as to whether you're looking at TASS or endophthalmitis. The corneal edema is characteristic too and can extend from limbus to limbus. Previously, there were more issues with what's called toxic endothelial destruction syndrome, which is thought to be toxins accessing the anterior chamber. Fibrin is very characteristic, and inflammatory membranes are just about always seen with TASS. It does respond rapidly to topical steroids, but it can cause late glaucoma due to the membranes sort of coating the inside of the trabecular meshwork. Next. This is an example of TASS. There's an inflammatory membrane. Next. To put it in a table, we can see that with TASS is more likely to have an immediate onset and minimal pain and blurred vision, whereas infectious endophthalmitis, or IE, usually presents a bit later, usually with much more pain and blurred vision. The sort of appearance of TASS and its features are similar to endophthalmitis, but differ in some important ways. The more inflammation there is likely to be, and if there's a vitreous involvement, it's more likely, and pain, it's more likely to be endophthalmitis, for which you would consider doing a tap and inject. Whereas if the patient's relatively comfortable, but have a lot of cells and even a hypopyon, that's more likely to be TASS. I realize that this is not a hard stop and go rule, but it's something to think about when you're trying to differentiate the two. So rapid response to steroids with TASS and no response at all with most, in most cases of endophthalmitis. Next. Here's another example of an early TASS, and you see the symptoms can be absent, as you can see it's a quiet eye. Next. So the outcome, however, is usually excellent, and that's the saving grace of this condition. Best corrected vision is usually better than 20/40, and it's rare to have poor outcomes. This can happen, though, if there are delayed diagnoses and management. In one of the outbreaks that I was responsible for trying to fix, 2 of the 17 TASS cases lost all useful vision. And that's because at the time there was a practice of seeing postoperative patients the day of surgery and then not again for 6 weeks. During this period, several patients lost vision permanently due to glaucoma from inflammatory membranes. Next. So the presentation is, as mentioned, it can be sporadic versus outbreak. Obviously, outbreak is a lot more serious in terms of how to resolve. Okay, and just about always, there are many factors involved in the etiology. The first response of clinics is used to make multiple changes before seeking help. So recreating the situation which developed the TASS is difficult. The most important places to look are the MDR or SBD, as it's called in many places, because the sterilization issues are almost always involved in the process of developing TASS. The FDA did a study and showing that of the leading causes, endotoxin, which is widespread in our operating rooms, can be a leading cause, often related to fibrin accumulating. Edema can occur from endothelial toxicity of detergents, preservatives, and gloves, as you will see later. Next. Looking at the leading causes, endotoxins on surgical equipment is one of the most common causes of TASS. from inadequate flushing of their handpieces, occluded tips, reused vacuum tubing and cannulas. Sometimes it's also due to inappropriate use of antibiotics. Enzymatic cleanings have been a real problem in terms of finding the place where they can be used appropriately, since if they access the anterior chamber, they can cause TASS, which can be quite severe. Generally speaking, we have a move away from the widespread use of enzymatic cleaners, but if they are used, it's important to ensure that they are kept clean. Antibiotics added to VSS is not being found to be useful, and there have been problems with the inappropriate dosages of intraocular anesthetics and antibiotics. Next. Other possible problems: insufficient cleaning of the ultrasonic baths, the use of a preserved epinephrine, getting some of the skin preparations accessing the surface of the eye and the anterior segment. Padded gloves have also been shown to be a problem, as I can show you a few examples later. More rarely, there can be contaminated IOLs and ophthalmic viscoelastic devices. Next. The key aspects of management are the use of intense topical corticosteroids for the first 2 or 3 days, and there's usually a rapid improvement in TASS. If there's not, then you might have to reconsider the diagnosis as endophthalmitis. Possibly systemic steroids can be used in severe cases, and also anterior chamber washouts can be a helpful method to wash out the severe cases. Intravitreal antibiotics, though, are not necessary. But again, it follows the mantra that when in doubt, it's important to tap and inject and not let endophthalmitis escape from your attempts to keep an intact anterior segment. And again, endothelial loss or glaucoma can be a consequence of TASS. Next. In terms of the best practices, and I'm thankful to Adam Musiak of the Canadian Task Force for these some of these slides. Certainly a strict adherence to the sterilization protocols that we all have in our operating rooms. Where possible, avoid reusing disposable items. If they are used, they should be thoroughly cleaned. For the sake of safety, we usually avoid detergents if permitted to operate by our regulatory without them. Certainly, it's important to maintain the traceability of the surgical supplies. And if you have changes in surgical supply, then this can also lead to sort of TASS in another form. It's important to review all the possible causes, and as you'll see later in the presentation, sometimes you have to search hard over several weeks and sometimes months to find a cause which is never found, but you can improve the process. So you have a general uplifting of the quality of sterilization that you perform. And the internal audits and protocol reviews can be extremely useful. We have one of our clinics that's been affected by TASS in Canada, which now have monthly audits to ensure that they know where their supplies are coming from, and they know how to deal with where to look for if problems occur. Next. Again, the most important person in the operating room is sadly not the surgeon, but it's your staff, and they're critical to the safety of your unit. It's always important to acknowledge the hard work they put in for us, and never leave the operating room without thanking your staff who will still be there cleaning up. Next, please. Again, looking back at the history of Orbis, how our understanding has evolved. There was a countrywide outbreak affecting the States in 2006. This affected 113 clinics and was found to be due to a contaminated balanced salt solution. And it took months before this was detected, and multiple clinics experienced this, including our own. Next. This culprit at that time was Endosol BSS. Again, it was what we call outsourced or contracted out and not verified as usual. And even more recently, despite all our knowledge of this condition, just 2 months ago, there was an outbreak of TASS related to contact lenses, the Envista IOL. Fortunately, this was rapidly brought under control and the lens was reintroduced. Next. Here's a description of some of the outbreaks we've experienced. The problem of endotoxin, which is everywhere where there's moisture. We see this more in, again, high volume multi-surgeon clinics. This one we followed over a 24-month period. And it is important because of the number of cases involved. See again the incidence about 2.1%, of which there are in this group of over 100 cases, 2 landed up to be endophthalmitis. So again, something to keep watching out for all the time. Next, please. I didn't put this up to intimidate everybody, but just to show how many steps one has to go through if we're having trouble controlling an outbreak. Remembering that half these cases you see will be associated with outbreaks. Obviously, in cleaning a protocol, short cycle sterilizers, and bimanual phacoemulsifications have also been shown to be problems if not well cleaned between treatments. This is a clinic that made multiple changes in their cleaning protocols because they just couldn't control the outbreak. The widespread contamination in the clinic was found on review. They changed the sterilizers and initiated the cleaning protocols. This was a case where the Endosol was involved. Taking all these measures did result in resolving the outbreak. Next, please. We have found that the use of what we call an epidemic curve can be useful, or a table. And by marking along a linear path like that, you can see noting the changes that are made and where they're made, and the effect on the course of the outbreak can be very useful, because you kind of can rapidly lose sort of sight of where the cases are coming from. So it is useful and to see how you can improve a protocol, but then a task can resurface again. Next, please. So this is one of the most difficult outbreaks I've been involved in. This was involved multiple cases of TASS. They led to closure of a major OR in Canada, and we had to change enzymatic cleaners, and we found debris and clogging the ports of the INAs that were reused, also stopping the enzymatics. We experienced 2 closures of the clinic in this situation. Next, please. This is another outbreak from a specific cause, which again is less common. This has occurred in one of our hospitals. One endophthalmitis case was associated with 16 TASS cases. Next, please. And here again, you can see how we've charted the epidemic curve, so you can relate to the different methods used to control this. We finally located it to the cleaning sterilizer, which showed the growth of biofilm on the inside. Next. And this is the Statum sterilizer that was previously in use. the great advantage of the sterilizer is that it's rapid, but the duration of action of heat is insufficient to kill the bacteria that may be within the sterilizer. And if not, there may be a partial kill, meaning that there's remaining endotoxin that can be found in the walls of the sterilizers if they're not adequately cleaned. This we did take apart in next. And you can see those are gram-negative rods encased in a biofilm, which is a protective coating. Next. And this is the free forms of Ralstonia piquetii. This was previously known as Burkholderia, but it's a potent gram-negative bacteria and can survive quite a significant cleaning. Next. Another outbreak with tabletop sterilizer occurred much more recently, occurred about 6 years ago, reported by Sorensen. Confirmation of the microbial biofilm on the inner reservoir walls. This affected 18 of 23 of the regional Statim sterilizers. Again, this can be simply corrected by cleaning the walls of the sterilizer or using a longer cycle. Endotoxin forms and is resistant, but it is not. But it is sensitive to a longer cycle. So that's how we can deal with that. Next, please. We described over 25 years ago the DLK, diffuse lamellar keratitis, associated with tabletop sterilizers. Same mechanism, linkage to the biofilm from the inner walls of the sterilizer. Again, the importance of inactivating the pro-inflammatory mediators such as gram-negative endotoxins, as showed you earlier. Next, please. This is another outbreak. This was a multifactorial causation as far as we could determine. Again, a high instance, 66 cases out of 1715. This led to a lid closure, a clinic closure for more than 3 weeks. And 24 changes had to be made to the surgical process. So you can see the impact of TASS and why we have to try and do all we can to keep it away from our operating rooms. Next. But here's some of the actions we had to take. There were multiple simultaneous interventions, including all aspects of surgery. The important issues from this was prolonged cleaning flushing of the handpieces, the discontinuation of vancomycin, which was found to be incorrectly mixed, and the flushing of the handpiece with BSS, which was regarded as insufficient. Next. And here's the remaining, some of the remaining 24 cases. You'll see there this quick rinse in the contamination process. This is a sort of a clever idea where to take the pressure off the staff having to clean the instruments by washing sterile water through them. It can be done automatically. The problem occurred, again, in one of our institutions. Next. Was that the tubing became contaminated. Again, we made multiple changes to the process to eventually resolve it. Next. Here's another outbreak curve, and you can see how different actions were taken, and there's the response. Next, please. This was an interesting case where blood powder was found to be responsible for TASS. All 13 cases occurred with one surgeon, but his found to be the technique he was using to load the lenses. Next. And you can see the touching of the tip of the inserter with the gloved hands was how he was loading it. Next. And this is what was on the gloves, this residue from a specific glove type. Once we stopped using this glove type, we were able to resolve the outbreak. Next. So it's a condition that keeps us on our toes and having to think about what the possible causes could be. Next. And here's obviously the solution, preloaded IOLs, which many of us use now, and the disposable INA tips. But again, not all units are in a situation where they can go to disposable ways to control TASS. Better to try and prevent it, because there's also a move, obviously, from environmental reasons and cost. We want to reuse all we can without initiating TASS. Next. Just to go through some recent outbreaks you may find of interest. We had one treated as endophthalmitis, but was shown not to be. But you can see how dense. Next, please. You can see how dense the membranes can be in TASS. And this all resolved with even the large pupil. We could resolve all that with just topical steroids. Next, please. And here's another example of using the use of the disposable INA tips. If using disposable INA tips, we've also found that when you handle the sheaths, that can sort of negate your previous action in using disposables. So it's good to check to make sure one problem doesn't go on to cause another. Next, please. This is this automatic washer, and you can see that that brown tubing down there. This was never cleaned from its institution 2 years previously, more because there wasn't a protocol for it. But you can see the danger of having that. We were able to just change out the tubing and do this every month, and we haven't had any further issues. Next. Staff fatigue is an important aspect. We found that we've had a big push to try and get our cases done, given the volume of surgery and the pressure after COVID, and the volumes have gone up, as has some of the cases of TASS, often related to taking shortcuts through the cleaning processes, and it's understandable. So if one's really caught about what might be happening and causing TASS, why it may persist, staff fatigue may be an aspect. Next. Of the most recent outbreaks, again, we haven't found significant risk factors in many. That doesn't mean to say we failed, because it invariably means that the process has been improved significantly, and the proof is that you can control TASS. But the message is that you don't always get the answer. But cataract surgery remains vulnerable to unpredictable outbreaks. And particularly, again, the effect of COVID has been significant. Next. Another example of TASS, and this is, you could see how easy it would be to confuse this with endophthalmitis. And again, not to go on too long, but when in doubt, it's important to tap and inject. Next, please. This was an outbreak related to tap water, we believe. There's 35 cases of TASS. The unit was closed down. Multiple issues related to their SBD. Staff issues, again, working in a very confined space, and use of the quick routes that we showed you earlier. Some of the outbreaks become quite puzzling to solve. There was one in a hospital where it involved specifically one surgeon, one nurse, and one room. And when things were changed, it was corrected. Next. This is one of the most recent outbreaks. And again, remembering that the number of cases gone down 10 times in sort of 16 years, we still have TASS. This is a tale of 2 outbreaks. They were both fairly close to each other. One was in a private institution and one in a public. And that's in the part of British Columbia, in part of Canada we live in. 34 TASS cases occurred, and we were requested to try and help. We didn't find a specific cause initially, and we took a fair bit of time to try and resolve this outbreak. We never found a specific cause, but it suggests the proximity. We had us thinking of maybe something more widespread, which would be the water source. The communities were having water shortages, and there were some issues with the pipes and the processings there. So we think that may have been the cause. Next. Here's the use of an outbreak curve, again, to track the cases happening. There's 300. So 19 TASS cases, 7 additional cases recorded before the intervention. And you can see how of the incidence and changes over the course of the outbreak. So you have to make multiple changes, see the effect. If there's none, then continue, and then try and resolve it and find the cause. Next. This is the other clinic, which showed 15 cases. And again, this temporal and proximal association. Next, please. In this situation, we suggested they go to reverse osmosis water filtration, and did a complete revamp of both operating rooms, ensuring that all devices were reprocessed by the end of the day and not stored wet overnight. We also required a MDR machine that does not use detergent, and to use exclusively for ophthalmic devices. When sterilization for eyes is mixed up with the general surgical instruments, there are often issues. Next. So suggestions here was to switch to dilution of an intracameral Vigamox rather than use the community-prepared cefuroxime. We went to the exclusive use of disposable cystoterms, and certainly minimizing the cannula manipulation. One of the issues is that there may be a difference in opinion as to whether a case represents TASS. And we found that in some clinics, 1 or 2 surgeons seem to have a disproportionate number of TASS, but this was probably due to their diagnostic criteria being different. So if that becomes an issue, it can be useful to have a third party to assess the diagnosis as to whether it was TASS or not. Next. So to go back to the clinic that was causing outbreaks in our area, and again, we came down to 5 possible causes, again, of variation in diagnostic criteria, off-site preparation of intracameral drugs, the poor water quality, the use of reusable phaco tips, and issues related to the MDR. Next, please. So again, I thank Adam Chuck for some of the more advice about sticking to best practices. It's important not to hide cases. It's maybe obvious, but when most cases are going to improve with intense topical steroids, it's a temptation just not to report cases. But it's always best if you think you've got an outbreak to deal with it as soon as you can. And these suggestions that you will have, next please, on the various aspects of keeping your operating room safe and best practices. Again, the cleaning of intraocular surgical instruments as seen. Next. The ultrasonic cleaning, okay, keep making sure your ultrasounds are well washed and clean. And next. and the sterilization of intraocular instruments. Again, these are well accepted and in the protocols by which we all operate under. Next. Again, to the enzymatic detergents are still remain somewhat controversial, but the routine use not recommended with no clear benefits is the latest advice. Again, it's important where possible that you stick to manufacturer guidelines, recognizing that that may not always be possible for you to do in your units. Next. Yeah. Well, it's I think we come to the end of this side. We have the additional information available to you, which you'll get in everything which was on this presentation. If you want to sort of look a bit further into the issues of TASS. So although it seems a confusing and difficult area to study, it is critical that we keep our operator rooms safe and secure. We all know this, but particularly when we come under pressure with pushing out our volumes, and then we don't allow for adequate support to keep our surgery safe. Overall, excellent news now, and I think the initiative of the ASCRS should be congratulated in being partially responsible for making the tenfold decrease in TASS occur over the last 15 years.
The first question is, during vitreous tap and intravitreal antibiotic injection in the pediatric age group for traumatized endophthalmitis, how much of a vitreous sample is ideal for culture sensitivity that can be drawn safely? And kind of a two-part question, what gauge needle is needed for the vitreous tap?
A good question. I don't have the exact answer. I think it depends what your resources are and what's the process in your own facility. Usually, in our experience, you have to get at least the 23 gauge as needle is usually not enough. So we usually go to a larger needle for the tap. But usually the injection you need is about 0.1 ml.
The next question is, if TASS and post-op endophthalmitis coexist, how can the two be distinguished?
Sometimes that's not possible, but generally speaking, if you think of TASS as being inflammatory, but your patient is comfortable, that's the simplest thing. Whereas that almost never occurs if you've got endophthalmitis. The patient's in pain, and there's much more inflammation. And also, it would be rare to get, well, it'd be unusual to get a TASS picture with endophthalmitis. Usually, you'll have vitreous involvement. Having vitreous involvement is much less common with TASS. It's usually fairly clear. What's confusing, I think, is that when you look at the anterior segment, as some of those slides showed, can be very inflamed, and then that's what I find to be the problem cases. Whereas if you do ultrasounds or you kind of get a view of the posterior chamber in TASS, you find that it seems to be quiet. It's almost never the case in endophthalmitis. And so the more if you talk about a pan involvement right across the eye, that's the end of endophthalmitis. So. But again, your key is to if you're not sure, just to tap and check.
The next question is more of a comment, but perhaps you can also add your thoughts. So in Afghanistan, we don't have all of the clinical items sometimes, and nurses and doctors sometimes tend to use the same gloves. Would you have any comments on this?
I think you could just do the best you can. Right? In that situation, I think if you have a fairly safe water supply, then that's the way to go if you don't have gloves. That's probably better than trying to reuse the same gloves.
Our next question is, Can TASS present with a dilated pupil, 7 millimeter with fibrin?
Definitely, yes. There was one in the presentation I showed, which was exactly that. That again, it's hard to imagine that's not endophthalmitis, but no, I've seen the pupils as large as 7 or 8 and fixed, but surprising they respond well to just steroids.
Our next question is any advice for cleaning solution to use for flushing? Because sometimes it's not easy for single use.
No, I just think you use what you can, the highest level of water you can find in your situation.
Our next question has to do with bilateral cataract surgery. So do you worry that same-day bilateral cataract surgery could lead to more cases of TASS?
Yes, that was a major consideration when COVID led to trying to do, bilateral surgery. There's been extensive work done on that, and it's generally regarded that there are no, I shouldn't be too dogmatic, but as far as I know, there are no cases of bilateral endophthalmitis from same-day cataract surgery. Because all the ones they've researched and they've found that that's not an issue. Yeah. Which is obviously reassuring. It's not to say that we won't get cases or they haven't been reported. There may be, but there's no agreed upon policy. These policies are generally safe in the policies we come up with to do bilateral surgery.
Our next question is a fixed dilated pupil a feature of TASS? I've seen 2 patients with a fixed dilated pupil.
Yes.
Next question is, does using ringer lactates affect incidence of TASS or increase incidence of postoperative corneal edema during phacoemulsification?
I'm not sure, but I think the answer is yes. I think they can be problematic.
Perfect. There are some questions on managing and preventing TASS. I'm not sure if there's anything you wanted to just re-highlight there.
I just think the way you have the greatest success is just take it slowly, make the changes, document the changes you made, see what the outcomes were, and and then hopefully by doing it in segments, thinking it like that, you will be able to get to the answer faster and not to be disappointed if you just never find a cause. Because presumably what's happened, the response when you get an outbreak, is that everyone tries to make the changes immediately, it's a natural tendency. Obviously, we're trying to do that. But then it does mean that recreating the situation so you study it one by one, removing the potential or offending item is much more difficult. So, and I think so that's important, just to go, take it step by step if you have that luxury. Obviously, it's difficult, and you can see that the impact of TASS, on all these clinics have had to be closed, usually by regulatory. Some were self-closed, but it becomes a very expensive venture, and not to say nothing of the problem with the patients not being able to get their surgery. But I think that's, I don't think we can beat ourselves up that we haven't fixed it, because again, it's not an easy problem, and that's why prevention is a key. And again, to reiterate, there's the success that's that has occurred through the task forces that are set up in various countries have been significant, and they've changed the way we actually practice, ophthalmology. To get a tenfold decrease in a condition like TASS is remarkable, even if it took 15 years to get there. And you can see in our story, I want to show the case that we have, the more recent one, that TASS hasn't gone away. It's just always going to be there. It almost, in a way, it's a safety measure for us to think that TASS is the warning sign, that we may be just pushing things too hard and we need to research a bit more.
Our next question comes from Ghana. So they had mentioned they had a TASS outbreak over 1.5 years with over 15 cases, all delayed in presenting at day 5 or later. They made many changes, but it kept reoccurring. Finally, they substituted intracameral moxi from Orolab with cephroxamine dilated by us, and they haven't had TASS since.
That's an excellent result, and they should be congratulated. I've been familiar with several outbreaks that have had also that experience. We saw it in our studies too, how intracameral antibiotics can be friend or foe, and we found it when we were off-site. Drugs that were prepared off-site for injection can be a problem if you don't have direct supervision yourself. But that's an excellent result, and shows how you just sometimes just have to be patient, just keep at it until you find the cause.
Our next question is 4 parts, so maybe I'll give you the first 2 as a start. So can we have a local antibiotic besides steroid in TASS, just in case there's also endophthalmitis? And what better option and cost-effective if we change the use of detergent? No,
there's no downside to doing the antibiotics, as far as I know. It's just that it's a lot of medication, and it's probably not necessary to give intense topicals or intraocular steroids if you're suspecting TASS. But I don't think anyone would be faulted for doing that. It's just probably not necessary. Well, I mean, in most cases, you just use a detergent as prescribed. But I think in many areas, and this depends, it's a local phenomenon. You have to see what agents they have been using. What is reassuring, though, is that we can do the surgery without having to use enzymatics, right? If you just flush, if you do more of the cleaning, then you don't have to use enzymatics. Enzymatics are only a real problem if it's the residual that's left after cleaning. That's the issue. So if you can clean your instruments really well, I think you can use enzymatics. Because sometimes if it's conflicts with the IFU or the instructions for use, then regulatory may not let you proceed unless you use enzymatics. So in that case, you basically have to use them. But that's been a long debate with the ASCRS TASS unit, is that they've generally gone away from recommending the use of enzymatics. And I think that's probably true in most of certainly the facilities in Canada. There is limited use of enzymatics, and they're used but with longer prolonged cleaning methods. And then you're just talking about the additional cost from staff time if you do enzymatics. So I think there's a big cost difference.
And just the final 2 parts of that question are, can we give a cycloplegic agent for the pain? And how long would we give the steroid, local or systemic?
You can dilate the pupil. There is a risk that they'll be permanently dilated if it's used for too long a period, because it's a very inflammatory mix you have in there, and that's going to readily form membranes, as you saw. Generally speaking, if you're looking at TASS, you want to use something like prednisolone 1% at least every hour. and even go through the night for the first 2 nights. So you want to be using really intensive steroids, and then you can back off pretty quickly though. You can see, once you start getting any change at all, you can back down to 4 times a day. So it's a fairly quick response you should get with TASS. But don't be afraid of using lots of steroid. Systemic, we don't usually use as much. Usually do that as a pulse dose, 2 or 3 pulse doses in the advanced case.
We have another question on flushing. So do you recommend distilled water for flushing instead of tap water?
Yes. Yes. Sterile distilled it comes in various forms, but I think the highest level of water you can get is probably worth the price, because you can see even the case where we had, like I think the one we had was probably related to water too. The one they had the 2 clinics separated by about 100K. The ones that had the water problems, and we've seen that, and with rusty pipes and things like that are you see in the ORs, they to use that to clean instruments, you can see how it could be possible toxins, and certainly those do happen. So basically, a highest quality of water you can get, without breaking your budget.
Next question. If hypopyon is present on first day post anti-VEGF, does it incline more towards TASS or endophthalmitis if patient has no pain but decreased vision? Vitreous is involved also after 4 days.
I don't know that one. It could be either. That's a difficult situation when they're both involved. I think you just have to treat as both.
Next question is, how will you counsel a patient who had TASS in one eye and is due for surgery in another?
Well, obviously, you're going to see whether it was just a sporadic case in one eye. Was the case surgery a bit longer? Was there a bit more inflammation? If the first eye was completely uneventful, but TASS occurred for the patient's other eye. This is not backed by any dates that I know of, but I would double my use of steroid if that occurred with the second eye, and tell the patient, the changes we've made is a very rare occurrence. Usually it's an excellent response like you had. I think it's safe to proceed, and we'll take a measure to increase the amount of anti-inflammatories we give you. And I think I would probably say that in a situation where the patient has that experience.
The next question is on the main mode of treatment. Just to confirm, is topical steroids intensive the main mode of treatment?
Yes.
Does oral steroids have a role in treating TASS?
Yes, I think so, particularly in the severe cases. Also, it's reassuring to know that the patient's got, you don't depend on the patient or other factors to do the drops every hour or so. But no, systemic steroids can be very useful. We initially didn't use them, but increasingly, I think they've been used as in short term more widely than they were before. I think it's a good option. I think we're probably just underuse the systemic steroid a bit. I think a few days use is probably better than not. And again, it covers those patients who may have questions about their ability to use Q1H steroid.
The next question is on detergent again. So would you recommend, what would be the best detergent to use in cleaning instruments to prevent TASS?
I'll be controversial and say no, none. If you follow the guidelines that we have in North America, then TASS use is minimized, and we only use it when we have to, and then we take additional cleaning to compensate for it. Just that we've had bad experiences with detergent, and I think it's been accepted. It's a long-running debate, which I'm more familiar with, obviously, North American situation. There's been a long-running debate with the FDA and the industry or the like a membership like the ASCRS sort of counts as to whether we need to use detergents. And it's come down to, I think, individual preference and what regulatory in your area want to do with it. Ideally, you want to use a minimum amount of detergent and keep it well and really clean the instruments well if you're going to use detergent.
Thank you. The next question is, can TASS cause post-op corneal endothelial dystrophy, and how should this be managed?
Yes, it can. You can get endothelial damage, particularly if it's the sort of offending sort of incident has been, it's more likely to be in my experience, a toxin that's been injected, from, for instance, cleaning materials we've used to washing of the eye and things like that. But again, if you if you can wash everything off, then you'll be safer. And it comes down to just clean the instruments as best you can.
Do you recommend AC washing in case of TASS?
In severe cases, yes. In less severe cases, no. Because you don't want to add anything further by making it, going in and tapping it, because it may stir up more issues. So, but if in a case that's not resolving fast, then yes. If there's a lot of anterior segment, you can flush it out. So I would recommend that, but only in severe cases.
Can we inject intracameral moxifloxacin in solution for prevention of endophthalmitis, or is intracameral use the only way? The second part question is, how much exact amount of intracameral moxifloxacin in milliliters should be injected?
Yes, you can use intraocular injection of amoxifloxacin. That's probably the most widely used now. And I think for the exact dosage, then I would check locally and see what's available to you. You're welcome to send questions through to me. I'll try and do my best to answer them. I put it through to our team that we have, which has been so supportive in terms of TASS that we've dealt with. And so, if you direct them through to Orbis on the cyber site, then we'll do our very best to answer the questions. And a lot of it's kind of local information, like the dosages to be using is somewhat dependent on what everybody else is doing in the community and what your community standard is. But certainly we'll do all we can. And I just found this experience a very valuable one, and I've learned a lot and see how important the subject is for all of us. And it's just nice to know we're part of a big community and we can share all these ideas. And I really want to thank Orbis again for the opportunity to present, and to all of you for all your patience. And I hope I got most of those questions correct for you. So it's been great. And again, special shout out to Orbis for this role in educating all of us.